Good afternoon, everyone. Myself, Dr. Amal Shaji, Junior Resident, Department of Pathology, Malabar Medical College, Calicut. I am presenting a case of a 32-year-old female admitted with the complaints of pain and swelling in the left knee for 3 years. It was gradually increasing in size. There was no history of trauma, no history of fever, and there was no movement restrictions in the patient. Examination, the systemic examination of the patient was within normal limits. And on local examination, a mild lateral swelling was present in the left distal femur, measuring 8 into 6 into 4 centimeter. It was body hard, deep-seated swelling, sparing the articular surface. Distal pulses and sensations were normal. The capillary refilling time was less than 2 seconds. There was no scar, no sinuses, no external injury, no ecchymosis, no ulcerations, no erythema, no local rise in temperature, and no movement restriction. So as an initial radiological investigation, X-ray was done, which showed a lytic and sclerotic lesion towards the metaphysis of the left femur, and there was no periostal reaction seen. The joint articular surface was well preserved, as well as there was no fracture identified in the X-ray. And in order to further characterize the lesion and to know the extent of the lesion, an MRI was done. So the MRI showed a heterogeneously enhancing lesion towards the metaphysis of the lower end of the left femur, and there was an area of cortical break, and the tumor was seen invading into the inner medullary cavity. So in MRI, they gave a diagnosis of periosteal osteosarcoma because it was very difficult to distinguish between parosteal and periosteal in MRI. And as in MRI, it showed a decreased ossification. They came to a diagnosis of periosteal osteosarcoma in MRI. Then they planned to send a true-cut biopsy. The true-cut biopsy showed a hypocellular neoplasm composed of spindle-shaped cells with a moderate cytoplasm, elongated nucleus, and tapering ends with fine chromatin. The tumor was also seen invading into the major trabecular bones, as well as there was osteodeposition and mild sparse mitosis was identified. So based upon the radiological findings and the Blanson morphology in the true-cut biopsy, these were the differential diagnoses we considered, like parosteal osteosarcoma, periosteosarcoma, and desmoplastic fibroma. So the parosteal osteosarcoma, it is mostly located in the distal femur metaphysis. In radiology, it is a dense ossified mass attached to cortex, and that is called as a string sign. And in periosteal osteosarcoma, this means mainly located in the diaphysis of the long bone, and is having a peculiar sunburst appearance in X-ray, and there is cortical thickening and is having a controlled matrix. Desmoplastic fibroma is in the metaphysis or diaphysis of the long bones. It's a lytic expansile lesion with the cortical thinning. Also, so fibromatosis of the soft tissue was also considered as a differential diagnosis due to the Blanson morphology. Along with these differentials, and parosteal osteosarcoma is grossly, it is having a lobulated ossified mass attached to the bone surface. It is having a dense osteoid mass matrix, and medullary involvement is rare. And periosteal osteosarcoma is a cartilage-rich surface tumor, less ossified than parosteal osteosarcoma. The matrix is mostly controlled and medullary involvement is rare. Whereas in the case of desmoplastic fibroma, it is a firm gray white infiltrative lesion with a word architecture. The osteoid and controlled is absent in the matrix in desmoplastic fibroma, and medullary involvement can be there. Microscopically, our parosteal osteosarcoma can have it is a hypocellular neoplasm, the spindle cells with mild nuclear atypia plus the trabecular bone. IHC wise, it is positive for MDM2 and CDK4. And periosteal osteosarcoma, it is an intermediate grade tumor with moderate cellularity and moderate atypia with chondroplastic areas and malignant cartilage and osteoid, and it is negative for MDM2 and CDK4. And desmoplastic fibroma, it is a low-grade blank spindle cells with minimal nuclear atypia in collagenous stroma. It is infiltrative and there is no osteoid, and it is beta-catenin positive. Fibromatous soft tissue, when we are considering, it is also positive for beta-catenin. And we proceeded the case with doing IHCs, and IHC showed a positivity for MDM2 and CDK4, showing a strong nuclear positivity. and beta carotene was proven negative. So based upon the history and the duration of illness and the radiological findings and the true-cut biopsy showing a hypocellular neoplasm composed of spindle cells with mild nuclear atypia and IHC showing positivity for MDM2 and CDK4, we came to a final diagnosis of pyruvate osteosarcoma. And the patient was further referred to oncology and was advised to fish for MDM2 gene amplification for confirmation. So fish was done and showed positive for MDM2 gene amplification. PET scan was done, which showed a FDG away light lesion towards the lower end of the metaphysis of left femur, as well as the plain CT showed an area of cortical break towards the metaphysis of the left femur. Later on, the patient was again readmitted with complaints of pain and swelling in the left distal femur within 1 month, following which a wide excision and reconstruction with the mega processes was done. And this was the wide excision specimen of the left distal femur, which measured about 15 into 6 into 5 centimeter, and towards the posterior end of the lower part of the metaphysis showed a gray white tumor, which measured about 7 into 6 into 5 centimeter, which was about 4 centimeter from the proximal margin and 3 centimeter from the articular margin. And the cut surface showed a gray white firm homogeneous lesion infiltrating into the inner medullary cavity through an area of cortical breeze, and there was no areas of hemorrhage or necrosis seen within the lesion. Microscopically, it showed a similar morphology like the true-cut biopsy with a spindle-shaped cells with a mild nuclear atypia, and the tumor was seen infiltrating into the inner medullary cavity as well as into the trabecular bones. There was also osteodeposition with mild nuclear atypia and sparse mitosis. So we arrived at a final diagnosis of pyruvate osteosarcoma of left distal femur measuring 7 into 5 into 3 centimeter, G1 well differentiated low grade with MDM2 gene amplification. So discussion part, this is the classification of osteosarcoma, and under the surface osteosarcoma comes the pyruvate osteosarcoma. So this is a diagram which is showing the difference in the origin of the pyruvate osteosarcoma and periosteosarcoma. Here we can see the pyruvate is arising from the outer fibrous layer of the periosteum, and the periosteosarcoma is arising from the inner cambium layer of the periosteum. And it's a low-grade pyruvate is a low-grade surface osteosarcoma arising from the cortical surface of bone. It is incidence is almost 4% of the total malignant bone tumors, and from that almost 22% is having an intramedullary extension, and mostly it is located on the distal femur posterior metaphysis. Other sites are the proximal tibia, proximal humerus. Other rare sites are the craniofacial bones, ribs and small bones. The clinical features include it is a slowly growing mass with a mild or occasional pain and long history is more than 1 year. Distal femur, if it is involving the distal femur, the patient can get a restricted knee flexion. And if it is a short history, it can suggest the features of, it can be a case of dedifferentiation. Imaging wise, it shows a dense lobulated ossified mass attached to the bone surface, the central dense ossification. The cortex can have normal, thickened, or can be destroyed. Pathogenesis MDM2 gene amplification and CDK4 amplification. Grossly, it is an exophytic lobulated mass attached to the cortex. It can encircle the bone, and cut surface can be hard, gritty, or tan white. Microscopically, there are areas of well-formed bony trabeculae, the spinal cell stroma, low cellularity and atypia, and very low mitosis. It is showing positivity for MDM2 and CDK4 in immunohistochemistry. And the diagnostic criteria will include the essential criteria with the surface bone tumor. It should be a pyrosteal location. There should be low-grade spindle cells with the bone formation. And the sub criteria includes the MDM2 amplification. Prognosis, it is having excellent prognosis, and 5-year survival rate is almost 90%. Treatment is wide excision and it is curative. Recurrence can happen when there is an incompleted excision, and metastasis is rare. It can be common in the case of dedifferentiated tumors. Chemotherapy is only for dedifferentiated cases. On follow-up, our patient had recovered well from the procedure and is stable, ambulant, and reports no pain, swelling, or any functional limitation. So this is a case report, and just like in our case, it's a 48-year-old female patient which had a similar history of pain and swelling in the left knee joint. And on the radiological findings was also favoring just like in our case, and fluid biopsy was sent. It showed a plan cell morphology with a minimal nuclear atypia, as well as in that case also there was the tumor invading into the intramedullary cavity, and wide excision was done and it was completely curative. So these were my references, and thank you.
Thank you, Dr. Amal.
Thank
So
you,
we'll
sir.
be concluding our meeting for today. Thanks everyone for the patient listening.
Okay, sir.